Hi there, Dr. Terry Schoenfeld for UAB Department of Medicine. In this video, which is one of a series of videos on interventions that might reduce perioperative cardiac risk, I'm going to focus on the role of revascularization. In a previous video, I made an argument that not a lot of patients need preoperative cardiac testing, and I think this video will attest to the reason why. Also, it's interesting to note that there was a study called the Decrease 5 study. It was a large study of preoperative evaluation. It's been discredited for academic impropriety. Thus, a large body of literature has been lost in this area. So, unfortunately, most patients don't benefit from revascularization in the short term. So, this is the Carp Study by McFalls and colleagues, and it remains the biggest study on perioperative revascularization. In it, veterans who were scheduled to undergo vascular surgery were randomized to revascularization. It was either CABG or PCI, depending on the anatomy, or medical therapy alone. And in this case, they got no revascularization. Of note, from a cardiac complication standpoint, vascular surgery patients are at the highest risk type of non-cardiac surgery. So if anybody's going to gain benefit, the highest risk patients should. And what this table shows is that in the group that underwent revascularization compared to the group that didn't undergo revascularization, myocardial event rates are essentially the same. No significant difference in event rates between the two arms of the study. And this figure shows that in the long term, there's really no difference in survival or death, depending on how you look at it, in patients randomized to revascularization or medical therapy alone. You can see these lines overlap each other. So what about even higher risk patients? Will they benefit from preventive revascularization? Well, Garcia and colleagues reanalyzed the Carp study that was done by McFalls to see if high risk patients gained any benefit, and they regrouped patients in the Carp study according to revised cardiac risk index scores, or the Lee criteria. And the higher the score, the greater the perceived cardiac risk of those patients. And what you can see is that post-op complications didn't vary by the RCI score. So as the score went up, the complication rates did go up, but they were the same between patients who were revascularized and those who were not revascularized. Thus, even the highest risk of the high-risk patient, because all these patients were vascular surgery patients, didn't gain any benefit. So why might this be the case? Well, this figure shows the pathophysiologic cascade thought to explain perioperative myocardial infarction. And you can see of all these things here, really none of them is fixed by revascularization. So it really makes sense that postoperative MIs can't be prevented by fixing a single coronary lesion, because there's so many other things that happen in response to surgery. So the American College of Cardiology and the American Heart Association released updated perioperative cardiac evaluation management guidelines in August of 2014, and these are the recommendations that they make. So class 1, they recommend revascularization before non-cardiac surgery. It's only recommended in circumstances in which revascularization is indicated according to current guidelines. The short of what that means is ignore the surgery and really only revascularize someone if you would have revascularized them otherwise, irrespective of the surgery. A class 3 recommendation, which means you shouldn't do this, is not recommended that routine revascularization be performed to reduce perioperative cardiac events. That's because the Carp study showed that there was no benefit. And really the only patients who might benefit from a perioperative PCI are patients with left main disease and who their comorbidities preclude a CABG, and patients with unstable coronary syndromes. And these would be patients you would do PCI anyway, irrespective of the surgery.